Hello, everyone. It's my pleasure to invite you all to the World Congress of Genetic Counselling second day. Before we start session 4, which is on genetic counseling in patriarchal society, I would like to remind you that all the speakers will give their talks first, but you are welcome to ask questions and put them in the chat box. All of you, I'm sure, enjoyed the discussions and the presentations yesterday, and I've had a chance to be in contact with each other through the spatial network. Today, the 4 speakers will be Dr. B.R. Lakshmi, who will be talking about genetic counseling experience in handling X-linked disorders in a patriarchal society, and she's taking Duchenne muscular dystrophy as a case. Sonika Sanjani Pulwani will be talking about the ethical and cultural challenges faced in genetic counseling in the UAE. Bijal Vyas will be talking about challenges of genetic testing and counseling in families with long QT syndrome. And the last speaker will be Nibi GE, who will be talking about the genetic democracy, dismantling patriarchal influences through education, empowerment, and being creative in genetic counseling. I hope you enjoy the session. Please remember to type your questions in the box provided below where the live session is going on. So without further delay, let's start.
Hi, and good day to all. Thanks a lot to the organizers of the World Congress of Genetic Counselling for this wonderful opportunity. And today I'm going to talk about our experience at MDCRC on genetic counseling of X-linked disorders in a patriarchal society. And we are going to take the example of Duchenne muscular dystrophy. And again, I'm from India and down south in the state of Tamil Nadu, and our center is in Coimbatore. And again, location matters in genetic counseling, as all of you know, because languages play a big role, the culture. So again, thanks for the opportunity, and I'm Lakshmi from India. And MDCRC, the organization which I head, is a not-for-profit foundation which works or focuses on public health initiatives, mainly for neglected disorders, and again, for the underprivileged. And this is a 10th year of our journey. And just on September 2nd, 2021, we completed our 10 years. And it has been a wonderful, memorable journey with a very challenging disorder, Duchenne muscular dystrophy. And we have been redefining Duchenne with our services and initiatives. And our services include genetic diagnosis, followed by genetic counseling, multidisciplinary clinical care, which includes rehabilitation, family support, and lots on field and outreach activities. And all is being offered free of cost to patients. And today, I'm going to talk about our experience of dealing with such an X-linked disorder in a patriarchal society in India. And again, when we say X-linked disorders, we have both X-linked dominant and recessive, and Duchenne comes under X-linked recessive. And the focus is Duchenne muscular dystrophy is one of the pediatric neuromuscular disorders. And we have varieties of muscular dystrophy, as all of you know. Especially Duchenne is X-linked recessive, while the other muscular dystrophies, most of them are autosomal recessive. And coming to Duchenne, again, we know it is the gene, the dystrophin gene, which is on the X chromosome. And a faulty gene gives rise to Duchenne muscular dystrophy. And there's an allelic form, that is the Becker muscular dystrophy, which is again milder. And again, with Duchenne as such, what makes it very challenging for genetic counseling is it is a pediatric neuromuscular genetic disorder affecting young kids. Again, the soft part of it, we already understand. And they are normal till 3 years. It's a progressive disorders. The children are mentally very agile, but they get onto the wheelchair in their early teens. Cardiac and pulmonary complications during late teens or early 20s, And they generally succumb to the disorder in their late teens or early 20s. Again, the mutation in the DMD gene encoding for dystrophin protein is on the X chromosome, and X-linked recessive affects only males, and females are generally carriers. So we understand the nature of a disorder. It's a lethal genetic disorder, affects only males, mainly kids. It's an X-linked inheritance. Women are generally carriers. And is there a cure? No. Again, this makes it even more challenging during a genetic counseling session. And again, the model which we are working at MDCRC is a community genetics model where we go into the rural to identify patients with Duchenne muscular dystrophy, and we bring them to the center, or we help them see the clinicians to confirm that it is Duchenne muscular dystrophy, take the samples, come back, do the genetic diagnosis, go back with the report to the rural to offer them genetic counseling. So it's a community genetics approach, a holistic model addressing Duchenne muscular dystrophy. Again, in the rural, women in the villages often become a victim of more number of health problems than in the urban one. Inadequate medical facilities in the rural areas, long distance of health centers from their home, and poor resources to obtain treatment from private medical practitioners are some of the major barriers, and which we are working for them to overcome by offering this community genetics model. And again, at MDCRC, we are setting a framework for integration of human genetics into the public health practice. So I'm going to share our experience with Duchenne's from the genetic counseling perspective of this X-linked disorder. So in our center, we have the main strengths are we have 4 wonderful certified counselors from Board of Genetic Counseling. Ethics has always been our priority. We travel across the entire state of Tamil Nadu, covering 32 districts. So prevention is a key. You identify to prevent it from the next generation. So we help the family be happy and have a healthy family. And again, genetic counseling is multifaceted for a genetic counselor dealing with such disorder, because they again need to be a psychologist sometimes, marriage therapist, lots of times grief counselors again. So the genetic counselor plays a multifaceted role. And again, the basic principles of genetic counseling, the ethical principles, forms the pillar of whatever we have been doing. That is the autonomy, that is the respect to the person's right, and the informed consent, which is very important, and to do good always, the beneficence. And the benefit should be defined by the person themselves. It is not what we think is important. That is what the genetic counselor thinks important. We have to think from the benefit of from the patient side again. And non-maleficence, not to do any harm in the process of genetic counseling, and justice, treating them equally. May it be the father or the mother, that is a male member, or the female, it has to be treated with justice. So this has been the pillar of whatever we are taking forward in terms of genetic counseling. And again, in MDCRC, first comes the proband counseling, that is the affected kid or the patient. So once we have the sample in the lab, molecular diagnostic is done, and then we confirm it, and then everything is done at the rural setup. So samples are brought from the rural to the center, analysis is done. Again, we go back with the reports where again a camp is organized, and we meet the patient one-on-one. So we invite them for the GC over phone, and they come in for the genetic counseling camps. There's a registration. And initially, to just give them a feel, we have a multifamily discussion group. And then we take them for individual counseling with their individual reports. And during that time, we brief the parents on the health of the child and what are the possibilities on a general note. And then we again talk to them individually. And then later on, we again talk to them on pre-test carrier counseling during the session. That is, we offer them the post-test proband counseling. We give them the report during the post-test proband counseling, and then talk to them about pre-test carrier counseling. And if they are willing, if there is a consent, then we take the carrier sample. And once the carrier sample is bought, we do the analysis, and we again get back with the post-test carrier counseling. And during that time, there are lots of opportunities where we do premarital counseling, extended family screening, psychosocial counseling, and need-based counseling like reproductive counseling, preconception counseling, prenatal counseling. Again, it depends on what the family needs. So to say at a glance, we are covering the entire state, and we have sort of counseled more than 3,000 families and more than 2,000 for post-test proband. And the carrier samples which we have taken is close to 2,700 plus. And post-test carrier counseling has been done close to 1,900 females. And for reproductive counseling, we have done close to 118 prenatal counseling. So the complete gamut of covering this disorder has been done. Okay, so all this has been done again in a patriarchal society. And when we say patriarchal society, we need to be clear between sex and gender. Sex we know as such is a male or a female, it's a biological difference. But when it comes to gender, it describes the societal attitudes and behaviors expected and associated with the two sexes, which again differs from culture to culture, country to country. And inherent sex learned gender. That is what is generally propagated. Gender is a social and established expectations for behavior and self-image for males and for females. And coming to patriarchy as such, we know it is a male-dominated sort of an environment where men hold the power and women are largely excluded from it. And when it comes to India, it's a very mixed sort of culture because, you know, India as a country has never invaded any other country, but India has been invaded from time immemorial. So many invasions have happened, foreign invasions. And so the culture is so mixed with all the inputs from various cultures. And now we have a pre-independence, that is a British era, and then we have the post-independence, again, which is from a very mixed sort of a cultural setup which we have. And again, in the global scenario, we see areas of global discrimination, where in education, women with lower rates of literacy, in politics, in terms of gap in pay, and violence against women. It is a global scenario. But here, with regard to X-linked disorder, for such a disorder, we are just going to share our experience in a patriarchal society. So coming again to Duchenne muscular dystrophy, we know it is passing of the X-linked condition. Generally, women is a carrier. And there is something a little different with Duchenne, where we generally know it is an X-linked recessive disorder where the mother is a carrier. But as I told you, we have the allelic form, the Becker, where the father, that is the Becker man, becomes a carrier. So this is a scenario where you also have a female as a carrier, and at times Becker, the male, is also a carrier. When the female is carrier, you know, when the boy inherits the X chromosome, he becomes an affected boy. And if the girl takes it, then she becomes a carrier mother or the carrier girl. But again, in terms of Becker, when the father is a carrier, all his female progeny or all his daughters are carriers again. So here, coming back again to the salient features of the Indian society as such, we have the caste system, the joint family sort of a base, which generally, again, it is in the rural areas, the marriage system, then the cultural lag. All this forms the whole community as such in India. And mainly I'm talking about the southern India, again, which refers to our state, that is the Tamil Nadu. And I'm just going to run quickly through various case scenarios, aspects of challenges in genetic counseling when it comes to Duchenne as such. See, in Duchenne, you have familial versus sporadic. See, the mother could have a family history, or she has a kid, but there's no family history and she is not a carrier. And then again, consanguineous and a non-consanguineous sort of a setup. Is she married within the family, or is it a non-consanguineous marriage? Again, where there is a kid with Duchenne. So it makes a lot of difference. Again, when it comes to a patriarchal society, whatever we have observed is the relationships of the man. So as a husband, we have always seen he blames his wife. Lots of divorces happen. That's lots of fight. And then there is a setting of understanding which happens with time. And then really it goes to a very understanding sort of a situation. Again, I'm saying most of it whatever we have seen takes this sort of a route generally when we refer to the husband. When it comes to a father, because we've been in it for close to 10 years, we have seen the husband was being so angry with his wife, who had, say, a 10-year-old daughter then. Then he goes through all these ups and lows. And then when he wants to understand the career status of his daughter, he really becomes so concerned about the daughter and becomes a very caring father as such. And as a brother, both affected or a non-affected brother, we always have seen concern of the brother towards the sister's family. As a son, we have seen it is lots of time influenced by the dynamics between the parents, how the parents carry themselves. Is a father always blaming the mother? Does a child get into him that it's because of my mother, I'm a Duchenne kid? So when you say men, and in a patriarchal society, the relationship matters and where they are. And it is a shock to come to know that their child is affected. And again, literacy, are they educated or not? And the geography where they come from, is it from the urban or the rural? So I'm just going to run through a few families to say here, gender inequality. Here is a family where there is a high level of family history, and here the mother is a carrier. But again, on the other side, the father is a carrier. But generally, the Becker fathers are not really blamed at all when the daughters are carriers and when they give rise to Becker kids. But when the mother is a carrier, there is a lots of blame game which goes on. And again, sporadic families where the mother is not a carrier, but she has a son who is affected by Duchenne. Though she is not a carrier, the general thought is, oh, there is a Duchenne kid, so the mother should be a carrier. Though we explain quite a bit, they understand. It takes lots of time for them to understand, and generally women are always blamed here. Again, lots of times it comes, they want a male heir. They want a male progeny. That is most important. Here in the family, you see, they have a daughter, they have a son who is affected, and they have already gone through the family planning. But once they knew the child is having Duchenne, so this is all they happened before they came in for the counseling. So they sort of reversed or did the corrective surgery and wanted to have one more son. And they were not aware of the disorder at all. And again, the son was affected with Duchenne. So awareness plays a very key role. So once it's identified, the counseling becomes very important. And here we could definitely, if they had done the genetic analysis for the other boy, we could have done a preconception and we could have helped them understand the state of the fetus of the boy who was born next to this one. But unfortunately, they didn't come in. And here, the need for a healthy baby boy as such. And unfortunately, it was a girl again, and they didn't want to go ahead, and they had gone in for an abortion saying, I don't want a female kid. Again, in terms of property, we have seen lots of cases where they need a boy, healthy boy, to inherit the property. And here it was a very sad family where the father felt very sad because he couldn't have a healthy male boy, and it was only the girl, and the girl couldn't inherit the family property as such. And again, there is a lots of difference when it is a consanguineous marriage. Here, if you see, the lady has married her own uncle, knowing there were two other uncles who were affected. But here she couldn't express herself. She was forced to marry her own uncle, and then she again had kids with Duchenne. But the only thing is, they were considerate to her because again, it's her own uncle. But if it has been one other family, should have been treated in a very, very different way. So getting into a consanguineous marriage where there is Duchenne and getting into a non-consanguineous marriage again makes a lot of difference. And here, this is a very special case where we had two brothers who were married to two different women from various other families. But unfortunately, both the brothers had children with Duchenne. So there was lots of blame game going from the female side as such. This is a very rare scenario, and just a few months back, we got this case. And so again, there is lots of awareness coming in, and women are getting empowered. And so when we come to Duchenne as such, these things should be kept in mind. And again, literacy, educated versus, we always feel it takes a longer time for the educated one to really take in to understand that they have a child with Duchenne compared to the not so educated ones. Again, urban, it is the same case. It takes a longer time for them to accept. So I would say empowering women and involving men would bring in closer to gender equality, and then being gender aware, being proactive, and having these included in the having gender aware programs, so will really bring us to light for many of such disorders where generally women are blamed. And these are some of our genetic counseling camps which we have done. So these are the discussion groups, the individual counseling sessions. These are career counseling, premarital counseling, preconception counseling. And again, now the challenge is a telegenetics. After the pandemic, lots of things going on in a telegenetic mode. It becomes very difficult for a genetic counselor because we are not able to really see who are close to the lady during the counseling or closer to the family while counseling. And the eye-to-eye contact makes a lot of difference to understand and be sensitive to the needs of the patient or the family. But that becomes a little challenging. And again, more it is only when it is a telephonic call compared to a WhatsApp call at computer. So these are just few pictures. This is our website. This is my wonderful team. And I always say growth is never by mere chance. It is a result of forces working together. And we are working with a Vision 2022 that our state, Tamil Nadu, will be a state where there is no kid with Duchenne who will go unidentified. So we identify and we help the parents have a healthy baby in the next generation. So if you want to go fast, go alone. If you want to go far, let's go together. So always we say working with such a difficult disorder, to do what ought to be done would not have been done unless we did it. We thought it is our duty. Thank you so much.
Hi, everyone. My name is Sonika. I'm a genetic counselor in the UAE. My topic today is the ethical and cultural challenges faced in genetic counseling in the UAE. So just a bit of a background about me. I have been working in the UAE since the past 10 years. I was the first genetic counselor in the country, and it took me a while to get on my feet and get a proper position as a genetic counselor. But still, I think there's a lot of progress still to be made in the field of genetic counseling in the UAE. Anyways, I'll move forward and I will talk about my experience in the past almost decade in the UAE. So here is the agenda for my talk. I'm going to start with talking about basic definitions of what is culture and what are the ethical principles to consider in genetic counseling, which must be common to many of you. You might already be knowing this. And then I'll dive a bit into the UAE culture, the geography where we are, the demographics of the country, and then more into our topic for today, the ethical and cultural challenges that we face in genetic counseling in the UAE. And then I will, towards the end of my talk, I will present 2 case studies in which I'll be focusing more on just the cultural and the difficulties that I faced while counseling these people. And then I'll just have one slide about the future of where I see genetic counseling, or where I hope to see genetic counseling in the next 5 years. So to start with, what is culture? The term culture can be defined as shared values, goals, expectations, beliefs, perceptions, or behaviors among a group of people who come from the same place or who have the same style of living. And why is this important to us? Why is culture such an important part of genetic counseling? Because common topics that are addressed in genetic counseling include reproductive decision-making, information about making health decisions about people's health, disability, and then in that, beliefs, practices, and values around these issues are so strongly tied to a person's worldview. And culture is thus an important integral component of the genetic counseling process and a significant aspect in providing successful and effective care to our clients. The American Board of Genetic Counseling practice-based competencies also include expectations about cultural competency and the ability to tailor your sessions to meet the needs of culturally different patients. Cultural competency thus can be defined as the ability to provide skilled treatment to members of divergent cultural backgrounds. So this is something that I found very interesting. It is the cultural wheel, and it lets you discover all the different ways in which culture manifests itself in people from around the world. So things such as food and drink, and the kind of art that people like to explore, the kind of traditions and rituals that you observe in people from different backgrounds, languages that we speak, and then we see that culture normally is something that passes on from generation to generation. And traditionally speaking, the elderly are the keepers of the culture and the tradition in families. So what are some ethical principles to consider in genetic counseling? Of course, this must be common to everyone. We've all learned this in our education. So autonomy is one of the ethical principles, one of the biggest ethical principles that we consider. And what does that mean? That is basically the right for someone to have the space to make their own decisions, and the right to make their own decisions without external influences of even spouses, parents, or anyone else in the family. And then there is beneficence, which is you basically do good, you promote good. And then, of course, on the flip side, also non-maleficence, which means do no harm. So our practice is basically, we are trying to help people, we're trying to do good by them. And of course, in the process, we don't want to harm them, and we don't want to do anything to inflict any harm or evil upon them. And then there is confidentiality, which is basically we want to protect the patient's privacy, the family's privacy, and we don't want this to be becoming common knowledge to the society or to their insurance providers, or in any way where they could be biased. There could be bias against them, or any discrimination against them. And then there is distributive justice, which was something that I came upon while I was reading for, preparing for this talk, which made a lot of sense. So, especially when we are counseling families, and there are multiple people in the family that we see, each session, requires us to be ethically just by that person in particular. Which means that sometimes some decisions which one person might make in the family might not be just by another person of that family. So our role in genetic counseling also involves being distributive, tried to provide or to try and at least give distributive justice across all members of the family. So each person should receive an equal share of justice, according to their need, according to their effort, according to what they provide, according to what they bring to the consultation. And then the last bit that this is also something that I came across while I was preparing this talk, role fidelity. And this really, strung the chord in me. Work within your scope of practice. So of course we are not, we would like to, I think as genetic counselors, and especially for me, I think I really want to help people always, but it's important to know where to draw the line. There are many questions that are posed in the consultation and people want me to answer them, but sometimes, for example, things like, how much is my risk going to be reduced if I have a risk-reducing mastectomy? It's not a question for me to answer, and I wouldn't, normally, I can't answer that question. So I need to know where to draw the line and refer on to a specialist who would be able to give the client the correct answer for this question. So to work within your scope of practice also, I've also seen this, and why this is so important to me is because I come across a lot of doctors and specialists who like to believe that they are providing genetic counseling. And, of course, we know that it requires intense training. We have gone through it. It requires intense training. It requires a lot of practice to actually be able to say you can provide genetic counseling. So I think it goes both ways. It's role fidelity. Everyone needs to work within their scope of practice. So genetic counseling in the UAE, this is just a little infographic about the UAE. These are things that people think about when you say UAE: the palm, the Burj, shisha, mosques, the camel, desert, dates. So a little bit about the UAE. The UAE is sharing borders with Saudi Arabia and Oman, and the common language, the native language is Arabic. We have a population of about 10 million people in the UAE. The capital is Abu Dhabi, although I live in Dubai and I have practiced in Dubai for the past 10 years. And then the demographics. So this was something this is very important about, and this is something very important to think about when I was preparing this talk. So my talk was initially titled Genetic Counseling in the Arab Population. And then I was reflecting back on my practice and I started thinking about, well, how many Arabs have I really seen, in the UAE? So it's very interesting to note that the Arab population, the population of Emiratis, is actually only about 11.5% in the UAE. And majority of the UAE population is expat, most of them being Indian, Pakistanis, Bangladeshis, Filipinos, so people from East Asia, Southeast Asia. And most of the UAE population, majority of the UAE population is between the age group of 25 to 54. So the main part of this talk, the ethical and cultural challenges faced in genetic counseling in the UAE. So some things that I saw, some things that I've come across. Now this is, again, going back to whether do I talk about the Arab population or do I talk about the UAE population? Something that is a commonality between the two is the Eastern culture of the population. And based on that, and based on my experience of that, these are a few of the things that I found was the challenging part of providing genetic counseling to this population. The large family structure, the family structures of the population over here. There is a high level of consanguinity in the population. So consanguinity, I'll come to it in the next few slides, is when you marry within the family. The large family sizes. People have many, many children, at least on an average 2 to 5 children. Multiple partners, the Islamic law allows for a man to have 4 wives. And sometimes I come across people and I'm trying to draw the family tree and I don't have space anymore. Where do I go to be adding all these partners and all the children that they have? The ethical issues of autonomy is very difficult to strive in genetic counseling over here because, this genetic counseling is not being provided just to the individual in front of you. It's actually applicable to the whole family and everyone is involved in the decision making. Which brings me to the next point, that these are patriarchal societies. The decision makers in these families are normally the men, be it the father if the girl is unmarried, or the husband if she is married. And even for young boys, it is generally the fathers until they are alive. And then the next thing is, of course, maintaining the confidentiality and privacy of people. It's difficult when there are some sort of things that come up in the family. It's difficult to be able to, it's very evident. The information that is in front of you is very evident. It's very difficult to hide it in front of the other family members. Obtaining informed consent, the level of awareness of genetic conditions, the level of education in medical science is quite low. And thus, when you're trying to when we practice the non-directive approach, when we take the non-directive approach to genetic counseling, people, I've realized, don't really want to know much. They just want you to tell them what to do. And I've had many patients who come to me and they just tell me, I don't understand and I don't care much about what are genes and all of that. Can you just tell me what should I be doing in this case? So it's very difficult to try and provide them with education when they don't want to be educated. They just want to know what to do. So it's very difficult to obtain the informed consent, because how much information can you give someone who does not want to receive the information? And then enabling communication within the family. So we see there is a stigma and a sense of shame around genetic disorders in the family. And, people don't want to share this information with their relatives many a times. Just this morning, I had a client who was talking about her mother and her brother who passed away at a young age from multiple cancers, which had metastasized. And I asked her, so how old was your brother when the first cancer was diagnosed? She said, this is a taboo subject. We cannot talk about this in the family. I cannot get this information. It's just not possible because we cannot speak about this. So the next point again is the non-directive approach, which I was saying it's impractical to be able to achieve that because of the level of education. And this leads to a source of miscommunication because you're trying to explain something and you don't know what the person in front of you is actually understanding, because there isn't much engagement sometimes. And then many people have asked me this, has language been a barrier? So like I said, the native language in the UAE is Arabic, and I don't speak Arabic. So interestingly, most Arabs that I have come across, and again, because I said the population is so multicultural and multi-ethnic, most of the people that I come across generally speak English. However, I do recognize that speaking someone's native language while counseling has the added benefit of being able to really relate with that person. And using terminology, especially such in the UAE, such as mashallah and inshallah, really add a level of comfort. You see someone, you can see in their eyes that they feel like, oh, this person gets me. So yes, that is definitely one point to consider. And then there's the religious beliefs, about, God willing, everything. I mean, even with regards to, should we do testing to make that decision for testing? Should we do testing? Some people don't want to test because they believe that, whatever God has given us, it's fine, it will play out. And why should we go about and try and fiddle with that? So religious beliefs also do come into the picture, and it is a bit difficult to try and navigate around that and try and provide that education that you want to from a scientific background. And also, more importantly, keep your own feelings out of it and keep your own emotions and beliefs out of that. So I picked two cases from my experience that I wanted to put forward and to bring over here. Now, just note that I'm not going to be focusing much on the science in these cases and the technology over here. The points that I want to mainly draw out by presenting these cases is the cultural and the ethical dilemmas that I faced while providing counseling over here. So the first case is related to a family with thalassemia and G6PD. It was an Emirati couple who attended the clinic, and they wished to discuss the union of their 20-year-old daughter with her first cousin, who was the son of the brother of the mother. Now they are aware, this couple is aware, they didn't bring this daughter to the consultation. They are aware and they know that thalassemia and G6PD runs in the family, and they also know that the boy is a thalassemia carrier. They wish to arrange, they came to discuss testing for their daughter to identify whether she is a carrier of thalassemia and G6PD. And they mentioned that the girl and the boy have already started talking and they seem to be getting emotionally involved. So before they really take a decision about getting them married, they wanted to find out, to have the testing done for the daughter. I did ask them that, and I did tell them that they would have to bring the daughter in, and I would like to meet with her and counsel her regarding thalassemia, G6PD, what it means to be a carrier, and what are reproductive options available to her if in case she and her partner are found to be carriers, but they did not want that. They just wanted to bring the daughter in, take her to the phlebotomy, get her blood drawn, have the testing done, and have the results delivered to them. So, of course, the ethical dilemmas and the concerns that came up to me that I struggled with was about the autonomy of this girl and boy in question. How am I going to obtain informed consent from this girl who is supposed to be having this testing? And then, how am I going to provide genetic counseling, and how am I going to enable them to make informed decisions for their future if I don't get to see this couple? And then also in the back of my mind was this thought that these two have already started talking, and what if they're already emotionally attached and have feelings for each other? How is this going to change everything? How is this going to change everything in that regard? So this was one of the cases, an interesting case. Following on, what happened was that they brought the girl in. I met her. I had a short chat with her. Still wasn't completely comfortable with the amount of information I was able to discuss with her, but at least she said she understood and she agreed to be having this testing. So the second case that I have is, so this has issues of consanguinity, of discussing this information in the family, of doing prenatal testing, and of course also the autonomy of the woman being tested or being offered the prenatal testing. So a young couple, a young Indian couple, in fact, consanguineous, their parents are brothers and sisters. They attend the clinic for prenatal diagnosis. This woman is 12 weeks pregnant, and it was their first pregnancy. So they recently found out that their cousin's son was found to be a carrier for homozygous deletion in exon 7 of in the SMN1 gene upon newborn screening in New York. And they had heard about this, and they came to genetic counseling to understand what this means and how this would be impacting them. So I offered them doing CVS for the fetus, and the wife seemed hesitant from the start. Her body language spoke ample. She was uncomfortable with the discussion. She wanted to, it's like, you know, she wanted to leave the office, and she just didn't want to talk about this pregnancy. It was like she was protecting this pregnancy by not letting anyone discuss it even, and, you know, not bring such kind of thoughts over it. While the husband was very enthusiastic about wanting to know more about the condition, and, you know, what was the prognosis, and, you know, how could we, you know, what kind of testing could we do to identify the status of this fetus. So after some discussion and after all this discussion, he convinced his partner to be having this testing. Now, the first set of ethical and ethical dilemmas that were raised for me in this session was the autonomy of the wife with regards to having this testing. She clearly did not want to find out what was, you know, anything. She was in disbelief that something could be wrong with her child. And then the challenges in terms of providing non-directive counseling and ensuring that the lady could make an informed decision about the test, about the condition, because she didn't seem to be listening. She didn't seem to be hearing what we were talking about, you know, without the influence of me or her husband. And then also that struggle for me, because in the UAE, we cannot offer termination of pregnancy. So in my head, I was thinking, God forbid, if this comes out positive, and if indeed this child is a carrier of SMA, what am I going to tell them? What am I going to offer them after that? 2 weeks later, the couple come to the clinic again to receive the results from their test. The fetus is found to be a heterozygous carrier of the deletion, so that's fine, that was okay. In the interim, the couple was informed by their family back home in India, that they were discussing the union of her brother with his sister. This brother is now settled very well in the UK, and they want to get this girl married to him. I asked them if they had discussed the past 2 weeks happenings with their family back home, and whether they had discussed that there was this question of SMA in the family, and whether this couple would be open to having premarital screening. And they looked at each other embarrassed, and like as if that, you know, this was some kind of secret, and it was something that they were hiding from the family, because, you know, if they brought this up to the family, it would cause some shame, and it would cause, you know, this is a shame upon them. So I asked them, and, you know, if they could bring this up with their fathers at least, and talk to them about having testing, or at least getting a premarital screen done for both these people. And they stated that this would be viewed as something really disrespectful, and they could not be involved in decision making regarding marriage in the family, and this was just something that the fathers would do, and, you know, they could not speak up. So I proposed whether they could speak with their mothers. They said no, they could not, because the mothers also would not be heard. And then I asked them, well, can you at least speak to the brother who was in the UK? Maybe he might, you know, be someone who would listen to them. They said yes, that seemed like a viable option, and they said they would discuss that with him. I offered to provide video counseling for the couple if need be, and they said that would be something that they would discuss with their cousin, and they would get back to me. Now, of course, the dilemmas raised over here is the culture of patriarchy, and how do you ask them to communicate in a way which is completely unacceptable in the family? And then that stigma around genetic conditions, they were feeling embarrassed to share with the family that something like this was happening in the family. And this was not their information to share, because the cousins back in New York who had this diagnosis had not yet shared this with the family. And it only shared it with this couple because they were close to this couple and they knew that they were expecting. So yes, the difficulty in communicating about the family members is also a big thing. In summary, the UAE is a multicultural and a multiracial population, and there are many, many ethical, social, cultural considerations to make while providing genetic counseling in the UAE, such as the ones I've discussed in the past. The future of genetic counseling in the UAE, well, the strength of the profession. So this picture is from a couple of weeks ago, where a bunch of us genetic counselors met up for lunch in the UAE, in Dubai. 10 years ago, I was the only genetic counselor, and today we're almost 10. So I could say we have multiplied tenfold in the past 10 years. Most of the genetic counselors in the UAE have trained from Western countries and have experience in Western countries. The UAE University is currently developing a master's in genetic counseling to locally train genetic counselors, which I think would be really, really wonderful. And it would improve the cultural competency part of genetic counseling in the UAE. Ideally, in the next 5 years, I would hope to see a general genetics clinic within all multi-specialty hospitals in the UAE with at least a clinical geneticist and a genetic counselor on the team. And that would be all. Thank you very much for your time and listening to me. And I would look forward to your questions in the Q&A session. Thank you.
Hello everyone, my name is Dr. Vijay Vyas, and I'll be talking about the challenges of genetic testing and counseling in families with life-threatening long QT syndromes. So long QT syndromes are inherited childhood disorder with a prevalence of 1 in 2,500. The QTC is prolonged on ECG, which is more than 440 milliseconds. But what is important to remember is that 33% of gene-positive long QTS carriers have a QTC value within normal range, and these can be easily missed if emphasis is on ECG measurement. They are known to have concealed long QTS syndrome. The symptoms are syncope, palpitation, hearing loss, bradycardia, and life-threatening events. Long QT syndrome is responsible for 20% of sudden cardiac death cases and 12% of sudden infant death syndrome. The peak risk of sudden cardiac death is observed in children and young adults. The triggers, ECG morphology, and response to treatment depends on the long QTS type. Especially long QT type 1, 2, and 3 have special characteristic ECG morphology and triggers. So the long QT syndrome follows an autosomal dominant and recessive pattern of inheritance. It also presents with incomplete penetrance and variable expressivity. There are 17 different types of long QT syndrome described till date. So there's a huge challenge for the genetic counselor when it comes to dealing with patients and the families with long QT syndrome. The first challenge is the complexity of long QT syndrome itself. Like I mentioned, it follows dominant and recessive inheritance. Majority of long QT syndromes are dominant, but there are some recessive type which presents with or without deafness. These syndromes also present with variable expression, which means that two patients with the same variation, one might have a cardiac event, maybe 1 or 2, while the other might have a higher number of cardiac events, which could also be life-threatening. Similarly, long QT syndrome also presents with incomplete penetrance. Again, two people with same variations, one might never have a cardiac event in lifetime, while the other might have the first event, which could lead to sudden cardiac death. In addition to the complexity of long QT syndrome itself, there are multiple genes that have been associated with long QT syndrome. Till now, there are 17 different genes described. And with the advent of technology and tests such as exome sequencing and genome sequencing, many more genes with pathogenic variations have been identified. When it comes to these, what comes with the variation identification is that we have to evaluate the pathogenicity by using ACNG AMP guidelines, which depends upon the population, frequency, disease association, segregation study, prediction tools, etc. And in long QT syndrome, the mutation type and location also has a huge impact. So for example, if we look at the homozygous or a compound heterozygous mutation, if it's a truncating mutation of a nonsense or exon skipping type, which causes a loss of potassium channel current in the ear, it causes German-Lang-Nielsen syndrome, which is an autosomal recessive syndrome with hearing loss. But if the potassium channel current is not completely lost, then it causes autosomal recessive long QT1 syndrome. Similarly, if it's a non-truncating mutation of missense type, and if it does not have an effect on the trafficking, it causes autosomal recessive long QT syndrome. But if it causes a defect in the trafficking or if the protein is not stable, then it causes a severe type of German-Lang syndrome. Similar thing is seen in heterozygous mutations. So besides the complexity of long QT syndrome and the genes associated with it, the main complexity comes with the variant of unknown significance. So with exome sequencing nowadays, we identify many variations, which when classified according to ACMG guidelines can be described as pathogenic, benign, likely benign, or variant of unknown significance. Now, these variant of unknown significance really need to be evaluated for the pathogenicity. So the counselor has to take extra care to obtain the detailed history, analyze carefully before making a genotype-phenotype correlation and coming up with a conclusion. For a genetic counselor, is much beyond genetics. They have to consider aspects such as family, psychological, social, ethical, and financial issues, while helping the patient make the decision regarding taking the test as well as with the result of the test. For this, multiple sessions with the patient needs to be conducted, and the counselor needs to be empathetic while the patient goes through different stages of emotions. For a patient, the positive genetic test and a negative genetic test have different counseling. If the result of the genetic test is positive, it can lead to health consequences and set limits to activities, especially in the pediatric cases. While a negative genetic test result can lead to anxiety and more expense on the follow-up test to confirm the diagnosis. In long QT syndromes, you're not only dealing with the patient, but you're dealing with the entire family. Identification of a mutation has an impact on the family. Patients with long QT syndrome can present with life-threatening events even later in life, so they have to be monitored regularly and maybe needed to be put on medications. Similarly, parents, offsprings, and siblings, if they are willing for the Cascade screening, need to be screened, and if identified with the variation, need to be monitored for symptoms. They need to make important life choices such as sports, occupation, lifestyle, pregnancy. Prenatal testing can be offered, but this has ethical issues, which needs to be kept in mind. So for the patients, parents, offsprings, and siblings all have to take precautionary measures to avoid any trigger situation that would lead to life-threatening events. Now I'm going to go through different patients. So a patient A is a 5-year-old boy. He had multiple syncope since age 2. His physical exam and electrolytes were normal. At age 5, he was referred to a cardiologist, where the echo was normal, where the QTC showed a prolongation of 520 milliseconds. Where the cardiologist had sent the patient to our genetic center for genetic testing. The counselor looked at the ECG and identified the broad T wave. Literature has shown that broad T wave is usually caused due to the potassium channel mutation, which is responsible for long QT type 1. So we decided to perform KCNQ1 gene sequencing, where we identified a heterozygous inflamed mutation in exon 6. When the parents were screened for the same mutation, the father, who was asymptomatic and had normal QTC, was also identified with the mutation. Here, the father was really shocked and worried about his own condition. So the counselor had to sit him down, had multiple sessions, and explain it to them that even though he has never had an event in his lifetime, he might still be at risk and need to be monitored accordingly. And the proband was put on therapy for beta blockers, which is proven to be effective in long QT1 type 1 patients. A patient B is a 49-year-old lady. She had palpitations, syncope. She was misdiagnosed as seizure since 30 years of age. She was seen by many cardiologists. Her echo was normal. Her QTC showed a prolongation of 510 milliseconds. She had torsiday pointers, tachycardia, and notch T waves. Looking at the notch T waves, it suggested the role of KCNH2, responsible for long QT type 2 syndrome. We performed the sequencing and KCNH2 mutation was identified. When we talked to the patient about her mutation, she had 2 sons and we had offered them genetic screening, but they were not willing at first. So we had to explain them the limitation as well as advantages of knowing the genetic condition if they have. So when they were willing, we performed the mutation screening, and both the sons who were asymptomatic were identified with the mutation. Now they were really worried about their status, and hence we asked them to be monitored by and recommended them to see a cardiologist to avoid any life-threatening event in their lifetime. The proband was implanted, an ICD was implanted in the proband. So this is a patient C. She's a 10-year-old girl. she had QTC prolongation, recurrent syncope, and the ECG morphology was not specific. On balance sequencing, we identified a variation in TRPM4, which is was classified as a variant of unknown significance. Now, this gene, which is transient receptor potential melastatin 4 gene, a transmembrane protein, was recently associated with long QT syndrome. So before giving them a conclusion, we had to look at the literature and determine if this variant of unknown significance is a real cause behind causing the phenotype. After studying this case further, a patient was counseled further and explained to them that this gene is a novel gene but could be associated and special care needs to be taken, and for this parental screening was advised, but they were not willing, so we helped them take the right informed decision whatever they wanted. A patient D over here was a 10-day-old male. He had a family history of 4 neonatal siblings death preceded by respiratory distress and cyanosis. His electrolytes and echo were normal. QTC was prolonged, beta blockers were recommended, and which reduced the QTC. The T-wave pattern was indistinctive of the type of long QTS, so whole exome sequencing was advised for this patient. On whole exome sequencing, another variant and TRPM4 gene was identified. Again, this variant was classified as variant of unknown significance. While we were doing the analysis, a proband died at 2 months due to unfortunate situation. Her parents were screened. His parents were screened, and the mother was identified with a heterozygous variation, but she had normal QTC and asymptomatic. In such a case, when the parents wanted to opt for prenatal sequencing for the next baby, it was not possible because of the nature of the variation, nature of the gene, as well as we did not have any DNA from the previous siblings. Our last patient, patient E, was an 11-year-old boy with a recurrent syncope and QTC prolongation. Again, whole exome sequencing identified a variation TRPM4. Here, 2 POS variants were identified. All the family members were normal with no symptoms, and the QTC was also normal. When the parents came to know about the genetic condition and the variants identified in the son, they were really worried about the other kids. So we offered them a Cascade Screening, which identified variations, a heterozygous variation, father and the brother. And the mother was also identified with another variation in a heterozygous state. So here the parents were really relieved to know that at least their daughter, who does not have any variation, and the son, 5-year-old son, has one variation, need to be monitored along with the proband. So a role played by genetic counselor in long QT syndrome is very crucial. First, to obtain the accurate information about patient and the family members and the symptoms, and explore the differential diagnosis. So long QT syndrome could also be caused due to prolonging drugs or such things and electrolyte abnormalities. So they need to be excluded before we decide to send the sample for genetic test to help the patient decide the right test. To explain the advantages and limitation of genetic testing. To correlate variation identified with symptoms by performing genotype-phenotype correlation. To make prognosis and advise personalized treatment and precaution measures to be taken by the patient. To identify at-risk family members and advise Cascade Screening. To analyze the screening results and make prognosis. Hence, the counselor has to take a patient-centered approach, which includes the aspects of medical, psychological, social, religious, and financial issues, and to help the patient adapt, understand the genetic condition, and make right informed decision. With this, I would like to thank my guide, Dr. Verma, Dr. Puri, and Dr. Saxena for the support and guidance. Along with this, I would like to thank cardiologists and geneticists for referring the patients, the patient and the family members, and the organizing committee of World Congress of Genetic Counselling 2021 to let me present my work today. Thank you very much.
Good day, everyone, and a special mention to the WCGC committee for giving me this opportunity. The goal of this presentation today is to contextualize factors like patriarchal influences and sociocultural diversity that are unique to practicing in India, ways in which this can be managed, and where do we go from here. The genetic counseling practice in the last 30 to 40 years has seen seismic shifts due to the path-breaking advances in genetic testing, which would have been unthinkable even in the 1990s. The fraternity of medical practice, and in specific medical genetics, The society we live in India, sociocultural norms that took centuries in the making, however, have remained rooted in a medieval past. One of the pillars of this past is a patriarchal hegemony that refuses to adapt. Nowhere in the developing world is this more strikingly evident than in India. It has been noted over the years that a population that is uneducated from a rural area and from lower socioeconomic status, and especially women and children, have at best limited access to genetic counseling services, as opposed to a group that is well educated and lives in an urban setting. Modern medicine has flourished as a profession enforcing socially constructed gender divisions, which traditionally ascribe decision-making responsibilities to men. The discrimination and barriers that women encounter as counselees is magnified when they're uneducated, come from lower socioeconomic backgrounds, and especially when their access to health services itself is restricted. I know from experience that this legacy continues to be an impediment in effective and timely care, diagnosis, and management. Out of all of these factors, poverty drives health disparities more than anything else. Genetic counselors are at a unique nexus between modern medicine and orthodoxy. India being a kaleidoscope of poverty, misogyny, superstitions, patriarchal prejudice, heteronormative ideologies, all of which are tightly knit into the genetic counseling practice, both from the genetic counselor provider's perspective as well as that of the patients. That the medical ecosystem often functions by these very principles is what one can philosophically call a Gordian knot. Some of the issues that arise because of a predominantly patriarchal practice is that patient autonomy is not always a priority, and directive genetic counseling is recommended. The report of abuse, especially physical or emotional abuse, if reported, there is no way to go report, or even the management of such reports remains a challenge. The infrastructure remains limited to resolve ethical concerns in biomedical practice in general, keeping in mind the limitation in terms of the number of genetic counselors or clinical geneticists available versus the number of patients. Individuals who are accustomed to traditional models of medicine in India, where a doctor, most often men, are seen as God, are frequently shocked at seeing a young female and not a doctor in a position of advising or as an expert. The statements that you see here on the slide are not statements made by older men alone, but older women as well. Situations like these require one to improvise on the textbook role of a genetic counselor or even the process of genetic counseling. Using a standard care, a single standard of care across genetic counseling practices, especially in non-Western setups, does more harm. Instead of having a single standard of care, I propose that genetic counselors utilize the core values of autonomy, non-directiveness, and put the counselee as a unit of a family first, where cultural and socioeconomic differences are recognized and respected in its entirety. I specifically mentioned the reciprocal engagement model here because it consists of mutually interactive, educational, relational, and psychosocial concepts that seem to work when dealing with such a diverse population. When working with patients from diverse and especially different cultural backgrounds as our own, I cannot emphasize enough the importance of prolonged consultations. This gives us an opportunity to understand truly where the patient is coming from, establishing rapport and building trust. Yes, one can argue that there isn't enough time for all the patients. But believe me when I say this, especially when using telegenetics, there are ways we can beat this challenge. Use tools and focus on compassion-based clinical encounter. Use open-ended questions to tailor the session to the patient's literacy levels. Genetic counseling is always a two-way street. It is important to assess how individuals or families give meaning to information that is shared in a genetic counseling session, especially when we are talking about a condition or a disorder within a family, or an individual who showed up with a personal history of a specific disorder. Instead of focusing on successful genetic counseling outcomes, I think it is important to look at appropriate outcomes, especially when working in a non-Western cohort of patients. From the patient's perspective, if we are able to help them understand management of the condition, if they're able to cope better, if the patients and the family feel supported, they're able to make an informed decision, I think that is an appropriate outcome. As far as a genetic counselor goes, I think the focus needs to be on providing anticipatory guidance and providing individualized and truly personalized information, keeping in mind the patient and family. Questions at the beginning of the session, such as what could be in the best interest of the patient, keeping in mind the cultural, socioeconomic status, and especially in India, family roles, gender, and overall well-being or safety of the patient. What are the 3 or 5 important points that my patient needs to take away from the appointment? Asking these questions right at the beginning of the session often helps in making sure that there are appropriate outcomes, both for the genetic counselor as well as the patient. The first step towards a way forward should be to acknowledge shortcomings in practice rather than justify this is how it has been or this is how it works here. Undertake efforts to re-engage those at the receiving end of such practices. I recommend that research must be conducted in an attempt to explore and better understand patient-level factors that impede genetic services, or even how a genetic counselor arrives at a consensus in various settings in India. Just as there are many psychotherapeutic approaches, I argue that genetic counseling can also have multiple approaches which can be adapted to suit the patient and the family. Exploring how individuals in such diverse socioeconomic groups, cultures with different literacy levels view genetic medicine is critical for genetic counselors to promote equitable uptake and implementation of genetic counseling services while avoiding deepening health disparities. Those are my reference, and thank you for being a wonderful audience.
Hello, everyone. Now we are ready for the question and answers. And Charlotte is going to help me moderate this. She's picked up some questions. So I'll start with the first one to Dr. Lakshmi. In fact, I'll combine 2 of them to you, Lakshmi. One is, are there male genetic counselors in India? And how do they serve in a patriarchal society? And the second one is, you haven't touched about counseling extended families. So is there an uptake for extended family counseling? Unmute yourself, please.
Thank you, Annie, and it's a wonderful question. Yes, we have male counselors, male genetic counselors in India, and I have, again, 2 of them, and I should thank Annie, because the first one, Mr. Suraj Manigandan, was referred to me by Annie, and I would say he's one of the finest genetic counselors I've ever met. And again, there has been some hesitancy, because when I took him, I at least would have asked Annie a couple of times, is it okay to have a male genetic counselor? Because it's, again, I work with an X-linked disorder. It's mainly mothers, and will they feel comfortable talking to him and all that? But Suraj proved to be one of the very fine, sensitive counselors, and he's been doing great. And I have one more, Sharat, and I think through BGCI now we are encouraging lots of more, because we need them. We need the numbers, and I would say they do wonderfully. And the second one, Sharat, and we, as we are touching in rural, they have to travel again. And for me, it's difficult to send female genetic counselors to the field as such. If it's just going in having a camp and getting back, it's okay. But if they have to stay 2 or 3 days in a particular rural setup and come, I feel better with male members. And the answer there is male genetic counselors do wonderfully, and my experience has been very positive. And with BGCI, we are going to have many more male genetic counselors. And it's going to be a strength for the genetic counseling on the global thing also. I think it's going to be a great strength. And coming
I
to
just
the
want
second,
to add here, we already have 10 certified male genetic counselors out of the 213 certified counselors that we have.
yes, and we should break the myth that generally genetic counselors are female. We should sort of break that, because generally, I think these are all lovely young men who are coming in, but then I think in BGCI, we are going to do that again. And coming to your second question, Annie, on the extended screening, carrier screening, yes, we do it to almost all the families. So I was just talking to the team, and we have covered close to 4,000 plus Duchenne families. And of course, we start with the index case and then do the mother. Of course, everything on consent. Then the sisters, if they are above 18. And then because it takes a while to create the rapport with the family, because to bring in the sister of the mother of the proband or the grandmother, sister's daughter, it takes a while. But we have done the extended family screening for at least 50% of our total index cases. And our experience has been wonderful, because they didn't have any clue. And lots of times in Duchenne, at least, they don't want to share that they have a Duchenne boy with the extended family. They have a taboo in sharing. So it takes a while, but I think it's very important, and we have been doing it, and the experience has been good as such.
Now to Sonika. What's your response when the family says that they all want to know is what to do?
That's one of the toughest ones. Good morning, everyone. It's a pleasure to be over here on this panel. That is one of the toughest questions. So what I normally do, again, it depends a lot about the rapport building that I have done previously, and to the point where I understand, are they going to be listening any further? If I feel like there is still a small window where I could give them at least some information so they know what would be the implications of the test, I would tell them that each person is different, and I cannot say what I would do in this particular situation, but I definitely can help you to make the decision. And these are the factors based on which some people make this decision, but for some people this may not sit well. So it's just about you looking into yourself and understanding which side of the coin do you sit with.
There's another question to you about the issue of abortion in the Islamic world, and how do you tackle prenatal testing in that situation?
So yes, legally abortion is not allowed in the UAE unless there is a clear threat to the mother's life, or that there is a clear indication that the baby is going to have a fatal condition. So it's very difficult. Generally, so what I have experienced, I don't get a lot of prenatal cases, but the few that I have seen, what we have had to do is, and like I said, most of the population is an expat population. We offer them to go back to their home country or someplace where they can access it if that's what they wish to do.
A question again, which I think any of you can take it. How do we manage the boundary of being culturally respectful and practicing in a culturally competent way without compromising the individual rights of women or other minority groups? Nibi, do you want to take it?
Sure, I'll take this up. So I think the first step that comes is awareness. And that's very important for the genetic counselor to be culturally aware, to be socially aware. And in my presentation, I did mention the importance of actually spending time with a patient to really understand where they're coming from, what their family background is like, who's the decision maker in the family. And so if you've spent that amount of time with the patient and with the family, it's unlikely that we would make recommendations that do not fit well with the overall value system of the patients. So I think it's important to be aware, use our skill sets that we've gotten during our training. So yeah, I think it's just utilizing our existing skill sets and making sure when you're in a new environment, when you're practicing in a different country, take some time to acquaint yourself with what is socially acceptable, what is the cultural norms in that country. So that's just my few cents.
Yeah, if I may add here, I feel that it's not just the country you are in, but now, even if you're practicing in your own country, like in the UK, there you see a lot of people from different ethnicities and cultures coming to you for counseling. And like Sonika said, she has the Arab people, but she has a lot of expatriates. The Filipinos are there. Filipinos, being Roman Catholic, have similar views on abortion, which are there in the UAE, the Islamic world has. So it's more the individual culture rather than the country you're practicing. You have to look at the legal issues of that country.
Of course.
Okay. Now,
I just add one more point over here that I thought about this after the presentation, but I do want to share the other side of the thing. I mean, I guess when I was making the presentation, it was just more about, the challenges that we face. But on the other side, the other things that we do also experience, or that I have experienced in the past few years, is I have met at least 4 to 5 Emirati women in their 40s who have come for primarily cancer screening because of histories of cancer in the family, who have shared that they are working, not married, don't have children and don't wish to have children, and they're very happy the way they are. So last month, I had a good rapport with one of my clients, and I asked her, I said, if I may ask you, if you really don't mind sharing, that what made you choose this way of life? I mean, was there no pressure in the family, or, how did you manage to get to where you are? And she told me, she said, when I started working, my brothers and my parents started seeing me as me. And they were like, oh, she can do it actually, she's fine, she's independent, she's okay. So they were fine with me making decisions for myself, and they were okay with me deciding not to get married and deciding not to have children. And it was such a refreshing, experience. And it was so nice to hear that as well, that, things are changing too. So I think what we need to also understand is that we cannot label cultures, and it's not like this is not allowed, this is not allowed. Every person brings their own individual culture to the consultation. That's just what I have to share on this point.
okay, now to Bijal.
And
you're on mute.
How would you do prognostic counseling for someone with a high risk for long QT syndrome? Can you also emphasize the ethical issues of prenatal testing for long QT syndrome?
Hello, everyone. So talking about long QT syndrome, it's a very complex syndrome. And when we talk about prognostic counseling for someone with a high risk, well, long QT syndrome has variable expression and incomplete penetrance. Besides it, we also have to look at it depends on the gene, sex, age, and the QTC interval prolongation. So it is not simple, to just do the prognosis that easily, but we have to look at these factors. If the variation has been identified, what gene it is it a potassium gene, sodium gene? But usually, after the first event, the first 2 years are very critical. So if they do have another event, then, of course, they have to refer to the cardiologist, and cardiologist probably will put them on a beta blocker, which is proved to be effective for at least long QT 1 and 2. For long QT 3, the trigger is, they usually have events during sleep. So that is very, very difficult to monitor them during daytime or even at night. So ICD is recommended. But that again, after you find the variation, you recommend them to the cardiologist, and they will look at the events, do the ECG, Holter analysis, and therefore, put them on the right treatment. So if you're looking in the genotype, phenotype, it is possible for type 1 and type 2 and type 3 because those are the major long QT syndromes, but it is a very difficult thing because even within family, we see a lot of variation. among symptoms, among the age of onset. So it is a difficult task, but can be done by carefully monitoring the patient and the family members. And about the second question, which is the ethical issues.
Ethical issues in prenatal testing.
Prenatal, right. So prenatal testing, has ethical issues no matter what genetic syndrome we talk about. For long QT syndrome, it can be offered, but then, like I said, long QT syndrome has variable expression and incomplete penetrance that, even though it is offered and the fetus might be identified, all we can, and the parents want to still get it done, we can offer it. Once the fetus, when the child is born, the child can be monitored and they can start giving beta blockers as soon as the baby is born. So it can be monitored like that, and the child can be saved from any disastrous event that can happen. Because I've had about 2 cases where the mother had six children and all of them died within the first month. When we had received the proband, he was 10 days old. And by the time we got the genetic analysis, we had already put them on beta blocker. But unfortunately, by the time we got the results, the child did not survive. So for the next pregnancy, the parents are opting, but the variation we identified again is, in a new novel gene, which has been associated with long QT syndrome, but it is not one of the main genes. So this has to be carefully taken over, and we have to look more in depth before we offer genetic counseling, genetic testing for the fetus. I hope I've answered these questions.
Okay, Dr. Lakshmi. There's a question which says that, do you feel it has helped patients and families understand more about their genetics and their different options available to them? Have you seen any more making appointments privately because of that? You give group counseling, you give all that. Do they approach you separately for private counseling?
Yes, I was just wanting to add, like when we say culture and other things, a genetic counselor, one of the key things is to do a good homework before you really go in for the counseling as such, to know about the complete pedigree, about the family, because with 1 or 2 sessions, we understand how the family dynamics is as such. So that is very crucial. Coming to Annie, what was the exact thing you had asked?
Myself, yeah. When you explain to patients and families, understand about the genetics and their differences in group counseling, do they come back to you as private? How many of them come back to you as private?
Yes. So normally we arrange these counseling sessions. Once we have a set of 20 or 25 reports, then we go back to the rural, that particular village or the block, to give back the reports. And only the positive ones we always take. If they are negative by MPCR or something for the post-test program, we are going to take them for MLP. So when we go there, we have one set of post-test program counseling where we have the whole parents sitting together, and we give lots of things in common, like about care, and give them motivation and other things. And we then arrange individual family post-test program counseling again. But during the counseling, we get a feel that mother wants to say something, but then she doesn't want to say. And lots of times the husband says, can my wife wait outside? I want to talk to you. Then the female says, can the husband stay back? But this happens. But one of the important thing is, because we have our numbers, that mobile numbers are there, we have had at least 24 mothers who have said, yes, we understand, and you have taken the carrier sample, plus please don't bring back whatever the results might be, negative or positive. Please don't bring it, call us for counseling and give it. I will individually get in touch with you to understand, because I'm sure my family can't take it and my husband can't take it. So it's going to be a ruckus in the family. So as each family has been different, Annie, and some families take up the overall what we give during the group discussion very nicely, and they attend the individual counseling as a couple again. And lots of times we have got in-laws coming for the counseling, the mother-in-law, the father-in-law, and the wife that is a mother of the child wouldn't be there at all, but the decisions are all taken by them. But then we give them a different type of awareness. And lots of times we have told It is not just the daughter-in-law. Your son also might have a role, because she already has 2 or 3 children, and breaking down the family at that point of time, no. So it's the awareness to the family and as a group. And lots of times what has really worked for us is group counseling for career positive mothers. So we have them all and they belong to the same community as such. And it gives them lots of strength to understand, yes, I'm a carrier, fine. And now I have people with who are also carriers, I can talk freely. And so the group counseling with carrier positive mothers in our experience has been very positive. And we have seen them take the inputs we give in a very nice way, rather than lots of times defending themselves. And still we hold lots of carrier positive reports with us because the mother has said, I don't want to take the reports. So that way, again, we have held it because I'm already 50. I'm not going to have, let me not know. You don't even tell me, let it be positive or negative. Let me not know. So we have sort of kept those reports with us. The experience has been varying.
Okay, thank you. Sonika, there's a question that is carrier testing done in the UAE prior to matching couples for marriage?
So there is, in fact, a government-initiated premarital screening program that runs in the UAE. However, the scope of that program is not what we would really call genetic carrier screening, but it is a good initiative. So it screens mainly for hemoglobinopathies and some sexually transmitted diseases, checks if the woman has had her vaccinations, checks for Rh factor. The couple is required, anyone who is getting married in the UAE is required to go to one of the public health centers, have the testing done. They say that we provide counseling and they tell them that, okay, we're going to be screening you for this. They have to go back to get the results within a week. And then that result is taken to the court, which they have to get stamped by the court. And only then can they really legally get married in the UAE. So in theory, yes, it is being done. My concern always with this program is the post-test counseling and how much counseling is being provided. Of course, the aim of this program and of no screening program is not to say don't get married. That's not the point, but at least to inform them and educate them about their reproductive options is what I would like to personally feel like would really benefit in the program.
Now there's a question for Nibi. As GCs, our role is to empower patients to make informed decisions. Should we or should we not empower female patients in a patriarchal setup to question the patriarchy? Does it come in nothing or purview or not?
That's a fantastic question and one that all of us struggle with on a day-to-day basis, be it in a prenatal setup or an adult neurological disorder setup. So I think here the importance is to focus on genetic counselors as being the patient advocate. And part of that role is to identify what would keep a primary patient or client safe, identifying the family factors, identifying what are the support system like. And oftentimes I've noticed that the patients who have met, it's the first time in their life that someone has asked them, what are your thoughts? Or why are you here? And that's so important in understanding and setting the agenda. I think most of us get carried away with, oh yes, I've gotten a patient for genetic counseling and this is all the information that they need. But sometimes that might not be the appropriate outcome. The appropriate outcome might be to identify and acknowledge their lived experiences and what would keep them safe. And sometimes, like Dr. Lakshmi mentioned, we might have a session with the husband and wife together. Sometimes we might have separate sessions. And even though we have prejudiced ideas sometimes as a genetic counselor that the husband, or because they're from a lower socioeconomic status, the family or the husband might not be very supportive. Patients and families have surprised me in my practice. And so I think in situations like this, yes, bring down the patriarchy, but at the same time identify what would keep our patients safe. And I believe in empowerment by education. So sometimes no one's informed or taking the time out to counsel or talk to the couple, as a unit of the family. And I think that's particularly where genetic counseling differs in non-Western setups, especially in Southeast Asia and Asian countries. So I hope that clarifies.
Now we are coming to the end of our question and answer session, and I think it has been really interesting. Please see to it that you all move to the spatial interaction session there, because there may be other people wanting to have discussion one-to-one. And there's one final thing till people give us a time, which is anybody can take this question, is could you throw some light on what practices and training genetic counselors need to make LGBTQ's community more inclusive? Anybody wants to take it?
I think it's a great question in light of...
You'll have to be brief, Nibby, because we are running out of time. You can take the question and be brief.
I think I know where the question's coming from, especially keeping in mind the issue that happened over Twitter last night. And I think it is our responsibility as genetic counselors and basic decent human beings to be respectful of gender fluid, non-binary genetic counselors, clients, patients. This is not something that we actively practice. And I think this is something that we need to be cognizant about and try and include this in our practice going forward.
So I'd like to thank all the speakers and all the participants who sent their questions. And I thank the team here who is helping us run this question Q&A session live. Please, there's also a discussion room where you all could go if you have a particular theme. Maybe the younger people, Sonika, maybe you could lead it and think of a session to take the Patriarchal Society discussion forward. And by the time I get a cue to end, I just wanted to tell about the thalassemia and screening programs. Every country has their own founder screening programs, like the UK has cystic fibrosis. I think Iran has thalassemia. So maybe the Saudi Arabia and UAE are taking thalassemia and other hemoglobinopathies together. Philippines takes G6PD as one of the things. And again, G6PD is X-linked. So, but luckily G6PD, if the only thing you need to do is counseling, and in fact, it could be a counseling done by, the US now calls extenders or things like that. Even genetic counselors don't do it most of the time, where we just give them information of what to do and what not to do. But policymakers decide based on the incidence information, and that will lead us to the other sessions which are coming today. And also we got one very interesting one last night about PhD genetic counselors who have a PhD, and what their role is. What is the type of research they should be involved in, which makes the genetic counseling profession go forward. Laura, do we have time? Because there are several other questions, but I didn't want to overstep our time. Is Laura here? Then I can just ask Lakshmi, because I think we have another minute. Lakshmi, in your clinic, you said that you do end-to-end. So is prenatal testing and pre-implantation genetics also part of the mandate of your society, where you will do prenatal testing and or you refer them to outside hospitals?
Yes, we haven't taken up prenatal and pre-implantation as big time, because ours has been more on identification at the rural and passing the proband, confirming for Duchenne, and then prevention, that is a carrier testing and the extended carrier testing. Of course, we have done at least, I would say, 3 dozen prenatal ones, where we help the couple as such to go through, and then we refer them to the gynecologist whom we have set up in our team as such, as a consultant. And pre-implantation, I would say we haven't done even one. We haven't the experience. But we of course help them, but we don't have a setup for prenatal, but we refer them to the appropriate gynecs in the various regions.
Any last minute thing anybody wants to say before we close? Any? Okay, so we'll continue our discussions in the forum and in the spatial networking area. Thank you. It was wonderful having all of you together.
Thank you so much, everyone. Thank you.